Well, let me start. Let me first recognize Mr. Laos, who's my AV expert, for helping me orchestrate this presentation by Zoom. Also, I want to recognize Ms. Alexis Watkins, who works in my office. She's my project manager and executive assistant. I want to thank her for her assistance. But let me start. As you can see, I'm miles away from you. The disaster that occurred in Colombia precluded my being there, and I regret that. But I want to send out prayers and condolences to the families who have lost family members, and those families where they're suffering with injuries, and my colleagues there who are obviously providing resources to try to manage this. With that being said, I want to have a heartfelt encouragement because, in all fairness, the Pan American Trauma Society wanted to do pivotal organizations for us in our discipline. But let me give you a little history on the United States side. The first trauma center was Cook County Hospital. It was founded by Dr. Bob Frioch and Dr. Robert Baker. Dr. Robert Baker was my attending because I did my residency at Cook County Hospital. So irrespective of what my colleagues in Texas might say, the Cook County Hospital Trauma Unit was the original idea of those two, but it was the first in the country. Let's go through this. It was the first comprehensive trauma center in the United States. And I'll go to the one I want to highlight. The Cook County Hospital Trauma Unit greatly influenced the growth and development of emergency radiology, of anesthesia, of laboratory support, and computerized trauma registry. Now, the Shock Trauma Center helped develop that even more so, but I'll get to that in a minute. And as a result of that was the proliferation of comprehensive trauma centers. So I'm going to recognize, because people think I'm not recognizing the other ones. Charity Hospital, Grady Hospital, Louisville Hospital, University of Texas Southwestern Parkland, Ben Taub, Memphis. I can go down the list. And obviously, San Francisco General, Denver General, but I'm going to particularly highlight the Shock Trauma Center where I did my fellowship. I want to recognize Dr. Sharon Henry, and I want to recognize Dr. Tom Scalia. To me, this is still a premier trauma center in the world. So I'll say that and I'll move on. Now, let me give you some other historical perspective. When I was at Trauma Center, these are the attendings who helped fine-tune LD Britt. And I won't go through all the names, but you see R.A. Cowley, you see obviously Dr. Burgess, Dr. Phil Militello, but the one I want to highlight, and the reason why I'm giving this talk, is Dr. Aurelio Rodriguez. This is Dr. Aurelio Rodriguez lectureship that I'm so proud to give. I've given over 230 visiting professorships, over 500 presentations. I'm the most honored by this because I'm honoring somebody who helped train me. So with that being said, let me talk about the Pan American Trauma Society. Let me also talk about my first, I think, major international meeting that I had was when the Pan American Trauma Society met in Sao Paulo, Brazil. I was hosted by this handsome man, Dr. Dario Berlini. He invited me to the home. I remember interfacing there with Dr. Kimball Maul, Dr. Susan Briggs. So my first major meeting that I can recall, international, was the Pan American Trauma Society. So I'm embedded in that. So I'm honored that you all asked me to give this talk. Let me start with acute care surgery. Let me disabuse anyone of any sort of illusion. It includes trauma, as you know, I authored it, but it includes critical care and emergency general surgery. I'm saying that we need to now, the next, we'll get into this, the next chapter for acute care surgery, in my opinion, is making it evidence-based management. I'm not quite sure we're there yet. So again, when I defined this specialty, my colleagues, a lot of fingerprints on acute care surgery. Trauma surgery was a cornerstone. Then you had emergency general surgery, which is something we added to this emerging specialty, and surgical critical care. Putting it all together, I felt that the best label for this, and my colleagues supported it, was acute care surgery. Not emergency surgery, because they would have gotten us confused with emergency medicine. and we didn't want that. But for some reason, there's been some sort of confusion. I call it some sort of maybe conspiracy paranoia, because people feel they have to add trauma. You don't have to do that. That, in my opinion, that hurts the brand. At the end of the day, you have to stick with the brand. Acute care surgery means trauma. It's a cornerstone. But I don't think we need to be redundant, but I'm going to leave that alone. If you have an acute care surgical surgery, you have those three components. And let's say you don't do trauma and you don't do critical care. Well, that's not an acute care surgical service. That is a EGS service, emergency general surgical service, which is fine. In some places, that is the service. But I wanted to just clear up any confusion. And there's some myths out there. The first myth is the evolution of the fellowship training in acute care surgery will adequately solve the access problems with respect to workforce shortage. The other myth is that the development of the strategy of acute care surgery will adequately address the major disparity in our specialty, in our discipline. Well, let's deal with the first one, the first myth. Evolution of fellowship training in acute care surgery will adequately solve access problems with respect to workforce shortage. Well, no. Yes, we have a good acute care surgery fellowship model, an excellent one at Shock Trauma, Pittsburgh, a lot of places. But we will not be able to produce enough specialists, acute care surgeons, to cover the need, at least in our communities in the United States. So the answer is no there for that myth. And how will we be able to fill that void in the community? And I've always been open about that. At the end of the day, this workforce shortage is really due to not having general surgeons. Now, don't get me wrong, but general surgery, most of the trauma and certain emergency general surgery is done by a general surgeon. Unfortunately, yes, we're trained in general surgery. We have general surgeons who don't want to do general surgery. They make general surgeons who want to do just breast, bariatrics, endocrine, HPB, and all that. So in all fairness, I think we need to have a call for a general surgery specialist. And I'll tell you what I'm trying to do in that effort. So now let's talk about the second myth. Development of this will address major disparities in our country there. If you look at the Institute of Medicine, which is called now the National Academy of Medicine, I'm a member of that, there's 6 aims of care. One, it has to be safe, has to be effective, it has to be patient-centered, timely, efficient, and equitable. We are not equitable at all. In fact, if you look at the widening healthcare disparities, there are all the disciplines: cancer, cardiovascular, diabetes, psychiatry, all can say they have severe problems with disparities that will give you adverse outcomes. So, with that being said, there's a push that you can call what you want. It doesn't have to be a general surgery specialist. You can call that person a broad-based, high-performance specialist. But we need somebody, because we don't have enough acute care surgeon fellowship trained specialists to provide that care. So the training paradigm needs to change. I'm a member of the Blue Ribbon 2 committee, for those who don't know, and you need me to send you the article, the original article on the Blue Ribbon panel, which was Blue Ribbon 1, but I'm on the second committee, looking at optimizing surgical training to accomplish what I just said. Not just acute care surgery, but let's make a more relevant, more well-skilled surgeon. And the particular focus this Blue Ribbon panel was started by the American Board of Surgery, along with the American Surgical, and was trying to look at the assessment of surgical education with a focus on patient care, on quality and safety, and a contemporary assessment of surgical education that will consider what has happened. We've had obviously universal implementation of electronic health record. We've had technological advances, increase in telemedicine, and a lot of things that we need to factor in our training the surgeon. Now, my recommendations, I predicted recommendations, I think they will come out of this Blue Ribbon panel that I'm on, will be you see here, to define and train a surgeon with the expertise in trauma, critical care, and emergency surgery to be able to provide some of that care in the community when you don't have a fellowship trained surgeon. I think that needs to be in the residency, the core residency program. As you see here, Yes, we have obviously some of the components, but one component needs to be acute care surgery in the curriculum, and I'm advocating for that. I mean, if you know, we have to. It's a lifelong learning for us. If you look at the beginning of the education part, you have 4 years of medical school. You have surgical residencies can be go from 5 to 7 years, and fellowship 1 to 2 years. But then after that, you still have to obviously participate in lifelong training. So I think we need to rethink the model. The acute care surgery model is a good one. And again, but one of the things we added to trauma, critical care, and emergency general surgery is surgical rescue, which I don't think we put enough emphasis on. I give Dr. Peisman a lot of credit because it was Dr. Peisman that highlighted this at the University of Pittsburgh Medical Center. He talked about the next pillar of acute care surgery should be surgical rescue. And why is that important? If you go back to an article by, in fact, what Dr. Peisman said, he said, it has become apparent to us, some of the Pittsburgh colleagues, that a crucial service we provide to both our hospital and region is surgical rescue. Now let's define that a little bit more. If you look at an article by John Berkmont and Justin Dimick, again, for those in the audience that I can't see, if you need original articles, I'll send them to you. They highlighted this. They said that if you look at complications, and that's when people die and they had to be rescued, you didn't rescue them, and so they had a complication and they had a death. It's not associated with necessarily whether it's a high or low volume hospital. What it's associated with is whether or not they have the ability to rescue patients. They put this out. If you look at it's not the complication incidents, it's not related to the volume of the hospital. You would think that's the case, but it's actually related to failure to rescue. They don't have that service that will be able to identify a complication and then obviously have early intervention and management. If you go to NISQIP, well, this is a database of close to 2 million people. If you look at it, 10.5% of patients have serious complications, including death. They had that because of failure to rescue. That's a problem, particularly in the surgical community. Let me go through this slide. 90% of operative deaths occur in the highest risk quintile. 20% of patients with the greatest risk of developing post-operative complications account for approximately 90% of failure to rescue. An important quality metric is the ability of surgeons and institutions to rescue patients who develop post-operative complications. Well, that service, that ability is the acute care surgical service. And in some hospitals, the EGS service. And then early intervention in a high-level intensive care facility with surgical program provides the best opportunity to reduce failure to rescue rates. So I do think we need to put an emphasis, maybe not and obviously in South America, but I think it's the same. We need to put an emphasis on how acute care surgery can address failure to rescue. Now, let's go back to my colleagues internationally. You know, this is my good colleague, Norm Williams, who was the president of the Royal College of Surgeons of England. He talked about it and he sent this to me. He said, they, meaning us, Americans, established a new specialty, acute care surgery, that embraced trauma, emergency general surgery, and critical care. Initially, there was much skepticism. He's right about that. Indeed, even hostility from colleagues, and he's right about that. But he said, I held this as a great success. Well, I thought that was a little premature. We're not quite there yet. There are things we need to do as a specialty. This was my original cartoon back over 20 years ago, 22, 23 years ago, highlighting the components of this specialty, as you see here. I won't go through it. But the problem we've had with branding, and I won't go through that too much, but let me do a little teaching as far as branding. I'm not a branding expert, but the most valued brand, for those who want to know, in the world is Coca-Cola, the most valued brand. So branding is important. So let's look at acute care surgery. Acute care surgery that's the brand. The categories include trauma, critical care, and emergency general surgery. So again, we need to continue to evolve. Forget the brand there. Let's talk about what we need to do to make a difference. The elephant in the room that no one is talking about, like you hired a crazy uncle in the attic, the elephant in the room that we're not talking about is the impact. Do we have evidence-based data to say that we're making a difference? Is it not based on lore, or I believe, because this is not a revival, it's based on evidence. That's the emphasis that in all fairness that I'm focusing on, along with Dr. Scalia. We're going to co-edit the third generation acute care surgery book. I'm looking at obviously there'll be new topics. I'm not advertising, but I'm going to highlight this in a minute to make my point. We're going to have acute obstetric gynecologic emergencies, surviving sepsis management, artificial intelligence, and as an adjunct to management of severely ill and critically ill, electronic health record implementation, the business model of acute care surgery. It's a great business model in all fairness. If you look at the busiest service in any hospital in America, major hospital, is the EGS service. And obviously the hospitals make money because that provides surgical rescue, all the things I highlighted before. They save money. So there is a business plan to this. So with that being said, I have right here, because I just wish I could be there. I'm looking at chapters that I'm going to consider for the textbook along with Dr. Scalia, but there has to be chapters evidence-based. I'm looking at one that's talk about the transfusion goals and strategy and adjunct therapy. Good one that has good evidence. I'm looking at one talking about the role of laparoscopic common bile duct exploration. What's the evidence that makes a difference, that we should go that route? I'm looking at one talking about obviously damage control orthopedics. So for those who might have something that is evidence-based, let me know. We might consider you to provide a chapter in the textbook. So with that being said, let me end with this, because you all didn't give me enough time. Next time I want you to give me an hour. Don't give me 15, 20 minutes. The arc of the moral universe, this is Martin Luther King, is long, but it bends towards justice. What Martin Luther King didn't say, it doesn't bend by itself. It requires effort and input and sacrifice. What I have said, the arc of healthcare is long, but it bends towards optimal care and inclusion, but it does not bend by itself. It requires interventions and modifications, some of the things that I highlighted. With that being said, in other parts of the world and all of that, I want to just say, there's a bright horizon there, in particular my colleagues in Colombia. I want to thank you for inviting me to be the Aurelio Rodriguez lecturer. I'm honored. Again, my prayers go out to you, and I look forward, hopefully, to meeting most of you all in person. I'll leave you with my favorite quote. This is Martin Luther King when he was in my city when I was a little boy. He came there, and one of the great quotes, not highlighted, but I think it's one of his best quotes. Our lives begin to end the day we walk away from things that matter. Once you walk away from something that matters, and you know people do that, your life begins to end that day, and I believe that. And I developed and did my whole career around that sort of mantra. So with that being said, I want to stop. I want to thank you all. Again, God bless you. Thank you very much.